So 4 Motrin and 3 glasses of wine would be better, right? So she pre-medicated herself. So that's why I put a question mark. Some women have that, some women don't. Now, anything that is added, such as a Valium or lidocaine injection, that's going to add to the cost of it. We don't do stuff like that for free. So let me ask you, those of you who have participated in an HSG with your patients, how were they with the pain? No problem? Mm-hmm. No problem?
I've had one.
Yeah, you had one personally, and there is pain, and I've had patients that
I didn't take anything.
yeah.
Besides antibiotics.
Yeah, typically we don't. Typically we don't pre-medicate. Unless next time you have one, I bet you will then. But I've had some patients, it's just some patients are very, good with it, and some are not. Exactly. And so you just never know. So the only thing that can be done is once the tube is introduced is to get the exam over as quickly as possible and make sure it's diagnostic and to get the tube out and that. Sometimes when the fallopian tube is kinked and the doctors may be putting a little bit more pressure to try to open it up, that can be a little bit painful too.
I seen a retrograde urethrogram on 2 of them last week, and the guy, when they tried to pump the contrast, he was snapping his fingers and banging his hands because it hurt. Yeah.
Oh, a retrograde?
Urethrogram.
Oh, wow. Okay, I haven't seen one of those.
Obviously, they never get them, but I had 2 last week. So.
Interesting,
yeah.
right? Something. Yeah. Have you studied that?
Yeah, we studied it in the urinary system.
Okay,
yeah.
good.
So
I know, weird how you don't see them forever, and then you'll get a.
Yeah.
It's all the doctor's ordering,
so he wasn't enjoying that exam at all.
No, it's not. Anytime you put a catheter into the body and inject anything forget injecting. Just putting a catheter in the body anywhere is not usually a fun thing. So again, your patients are going to have various levels of pain from no problem to extreme pain. So that's typically not something you can do unless the patient wants you to stop the exam. Then you stop the exam. Then they may be rescheduled with medication. And then sometimes, but I know for me personally, it's like, okay, it's painful, but I don't know if let's just get this over with. I'm here, we're getting it done, get this over with, hurry up, and you're killing me. Because we don't want pregnancy to occur, this is probably the only exam that you use the 10-day rule for. Remember the 10-day rule? You are not supposed to perform the exam within 10 days of what? The start of menses. The start. Everybody, it's from the start. Okay, so how long does a period take? And I laugh. Gentlemen, in case you don't know, yeah, and we don't know either.
You're talking about the bleeding part, right?
Yeah, the bleeding part.
Yeah, a couple.
2 to 7, 2 to 5. Some of us are longer, some of us are shorter. Some of us are shorter, but then 1 month it's longer. We don't know why. We just never know. And so, or maybe I'm just speaking personally, but so you have to schedule within 10 days of the. Okay, so everybody, how do you do that? Think about that. Okay, so I'm going to schedule a patient's exam for an HSG. We have to do it now. Your hospitals, and I say 7th to 12th day. Do you ask that question? It's the first day of your last. So you have to ask. Thank you. You have to ask the patient, what was the first day of your last menstrual cycle? Everybody, ladies, think about that. Just okay. Well, I was gonna say you don't have to. Thank you for telling me, but you don't. Okay, but not everyone can do that. Even though I go to the doctor and I know, ladies, don't they always ask you, when was your last menstrual cycle? I knew you were going to ask that, but I did no preparation for that. It was sometime, So hopefully they can tell you the first day of their last menstrual cycle. Now, the next question, how long is your cycle? Some are 28, that's not normal, but that's usually 28-day cycle is considered normal. And so then how long Is it 28 days? Is it 30? Is it 32? And is it consistently however long? So let's just say it's 28 days. So you think, okay, my last cycle was this date. Okay, 28 days from now, plus how long am I usually bleeding? 3 to 4-ish. Okay, so we'll go 3 days, let's do 4, and then we'll do it on that 7th day, or that 8th day, 9th day. Or you can go up to 12 just to be safe in case you're off a day or so, right? It's not easy. It's not easy to schedule a patient. And then,
I think that's a small portion if you're that lucky. Like people who are that regular. So I think more people are irregular, so you have to have them on birth control or something that will make, or just call when you start your period. And then
right. It is more people, I agree with you, from what I know, are more irregular than regular. And so, it makes it difficult. And then if it's great if you're like, okay, I started my period, can I have this exam in 10 days, 12 days from now? Well, we don't have an opening. Okay, so you see what I mean? So it's not easy to schedule this. And then, okay, so who are we scheduling this for? What's the number one reason for an HSG?
Infertility.
Most common, okay, infertility. If you don't know what these women go through, and their, and the fathers also, it is difficult. They're high stress, and they're anxious, and they finally got this scheduled, and you think they're going to want to reschedule. So if something's not right, or they're on their period, or they didn't schedule it correctly, they have to reschedule. And so it makes it very hard. So the thing is, we want to make sure, so you have to figure out your hospital's policy on that. So the 10-day rule is typically followed, or the worst case scenario is you want to make sure that patient is not pregnant. If you've got somebody who's trying to get pregnant, it's the 14th day, it's the 16th day, the 20th day, how do you know they're not pregnant?
Blood work?
There's only one way, and
Blood
that's by doing blood work.
Like for HCG.
Yeah. So
Right.
yes, for the pregnancy hormone. So that would be the only way to do it. And maybe that would be acceptable at your hospital. So you just have to find out what your policy is. So the procedure is, fairly simple as far as your job as the radiographer goes. Is the radiologist who's doing the hard part. And so the patient is put, and I think somebody mentioned that before, patients in the lithotomy position. Remember what that is? That is where the patient's on the table, their feet are in the stirrups, and their knees are bent and abducted, right? And so it helps to put the table into a slight Trendelenburg. So let's see, where would the patient's head be? The patient's head's down there, right? And then so the radiologist would be down here at the end of the table. The patient, a lot of times, do you have stirrups or do they just put their feet on the table?
Their feet on the table.
Yeah, the feet on the table, that's fine. Their knees are abducted, and they're usually draped, are they not?
Mm-hmm.
Okay, for privacy purposes. So the only one who needs to be here is the radiologist. You're doing stuff around, taking care of the patients, making sure the doctor has what they need. So the table, in a little bit of a Trendelenburg, just brings the pelvis up so that they can see into the vaginal canal without having to, they're usually seated, but
searching
still,
for it.
yeah, they need to see where they're going. So, so lithotomy or modified lithotomy position. The cervix is exposed with the speculum. So I have an HSG tray, and we need to know all the fun stuff that's in this. This is one tray. But let me show you what a speculum is, and you need to know what each one of these do. And so, guys, just so you know, if you're not familiar
Is that a cocking gun?
about to get an education. So this is a speculum. These used to be metal and just sterilized after each procedure so they could be cold. This is plastic, disposable, not so cold. They put KY jelly on here. What is this?
Cervix.
Cervix. So they're going through the vaginal canal, put it into this, oh, I misspoke. This is the external os, and so going into the vaginal canal is a collapsible tube, and so this opens the vaginal canal so that they can see the cervical os right there through the opening here. So this speculum is to open up the vaginal canal. So now they're looking at it through here.
Oh, okay.
Okay, you with me?
Mm-hmm.
So everybody, what is the device that, oh, I just broke it. What is the device that opens up the vaginal canal?
Speculum.
And these come in different sizes, but there's just that sound. Okay. So then cervix is exposed with the speculum. That speculum opens up the vaginal canal, and the cannula is introduced. There's a couple of steps before that point right here, and that is, okay, again, the cervical os, the external cervical os that we're opening is typically closed up. And so if they have look at the cannula. It's a very flimsy, small tube, and it's hard to get it in there. Maybe it'll go, maybe the doctor can kind of work that through that canal to the uterus, but it's a little bit harder to do. So they have what they call a uterine sound, S-O-U-N-D, and it's just a dilator. I don't know why they don't call it a cervix dilator, but they don't. It's a uterine sound. There's some notches on here that show the amount of dilation, but the tips are dulled and kind of like a little ball on it. And so what the doctor does, if they can't get the tube in there because it's so flimsy, they'll just dilate this. So they just put this tip to the cervix and just kind of work it a little bit to where it opens up. Okay? They may or may not need to use that, but that's what it's for, and it's on the tray. And that's the uterine sound. What does the uterine sound do? Opens up, dilates the cervix. Absolutely. So then the doctor will need to, well, probably before that, clean the area. You can't sterilize the cervix, but you can clean it. So here's, we call it a big Q-tip. Put the betadine on there, and the doctor, and it needs to be long, to, you know, so that they can go in there and clean the cervix. Okay, so then they open up the cervix and put the tube in. Now, just like a BE, you know, you're introducing contrast media into the cervix and to the uterus, and so contrast media is going to come back down through that dilated cervix. So there's a little balloon. Look at this. How cute is that? Right? It's like a little BE tube. Look at that little balloon. Isn't it cute? So now it goes through, and you kind of pull back on it, and it blocks the internal cervical os so that the contrast media won't leak back down into the vaginal canal. So it's just a little balloon. It's my favorite part. Okay, so then contrast media is introduced under fluoro. It's not really an injection, but it's introduced under fluoroscopy, making sure that going through the fallopian tubes. Oh, one more device. There's other things on here, but here's another one. Look at that. Those are extremely sharp. This is a tenaculum. It's a tenaculum, and that, okay, so sometimes the doctor will open the, it's not that big, open up the vaginal canal, and they see the cervix. Well, the cervix is not going to be right in the middle of the opening, typically. That would be nice, but in a retroverted uterus, because it's pulled back, the cervix is tilted up towards the floor of the vaginal canal. And so the doctor is like, so it looks like this. So here's the opening. You're looking through the speculum, and then here is the cervix. Or, you know what I mean? It is not right here where they can go, oh, there it is, and right there in the middle. Okay, so it can be anywhere, and so how are they going to get to that opening when the opening is facing the, the roof of the vaginal canal? So this is what they do. This is a device. The tenaculum is a device to grasp the cervix and pull it down.
Oh, lovely.
I am told that the cervix doesn't have any feeling and that they will not feel this. And I say, I don't believe it. Now,
How did it get it through without it?
well, let me tell you, remember how shiny the cervix, the uterus and cervix and all that looked, and the ovaries? There's mucus, it's slippery. And so you need something that will be able to grasp,
It's like,
it'll be grasping it and pulling it down. And not like yanking it, it's just tilting it so they can put the catheter in, okay? I say pull it down, manipulate it, turn it.
Give a little tug.
Yeah, not, if they were to do it roughly, it could. So they may get a little bleeding. If this is used, that may cause a little bit of bleeding, a little bit of spotting.
It's a little blood. Be all
I know.
right.
It's like, when I have one of these, I'm gonna look on the train and go, yeah, take that one. Reach over and throw it.
Mine lines up perfectly straight.
There is a, on this, and how nice, they have, guys, what is this?
It's a headband.
Is a feminine napkin to put in their underwear, because afterwards they have contrast media. They're gonna probably go to the bathroom after this exam. Some of it will come out, not all of it. So we give them this just to put in their underwear so that if anything leaks out, it's not getting onto their underwear. Doesn't stain or anything like that, but have you ever had contrast media on you? It's sticky. So it's just for patient comfort. So I've seen other trays, they don't all come with this, so, but you need to find one and give to the patient after the exam, okay? For the drape, we need a drape, although I don't, did they use this one? Right, I know, I was like,
makes everything more difficult.
now this is a, they call it fenestrated drape. This is great for a myelogram or an arthrogram where you're doing an injection, but I think that would hinder, I don't know. Anyway, we don't have to have a drape so much, but the patient needs to be, their legs need to be draped for modesty and privacy purposes. So I've not seen one, but this one came, unless it migrated somehow. And I found a needle. Here is a syringe and a needle on this tray.
To draw up the contrast, maybe?
Yeah, maybe so.
Because that's how we do it. Like when we do,
Yeah,
we have to draw the
that's right.
contrast, and then
All I can think about is
yeah.
lidocaine.
no,
Yeah.
to draw it up and then
Yeah,
inject
absolutely.
it.
Okay, so we have the needle for that. We have some extra tubing if the doctor wants extra tubing on this.
Is that a fork?
There's two.
Chopsticks.
Take a little snack, maybe there's a food cup somewhere. I don't know what these are for. So anyway, get to know your HSG
Kit.
tray. So I will ask you questions about that. What is a tenaculum? What is a uterine sound? What is the device that opens the vaginal canal? So make sure, and I have some pictures of those on here to help with that. I lost my clicker. And then after, typically at this point, and correct me if I'm wrong, ladies, you'll do the fluoroscopy, or the radiologist will use the fluoro images. And do you have to do any overhead after that? Do you have to do any overhead images? Get the x-ray tube and, okay, usually most images are taken using fluoro. So again, you need your fluoro room. You need to to set that up, you have your sterile tray with your equipment on it, sterile drapes or towels. The doctor may or may not need forceps. Sometimes they use the long forceps with cotton and dip it in the betadine and use that to swab the area. Oh, another thing, I don't know, the cannula with the balloon, the syringe, a gooseneck lamp or some sort of lamp. I don't know what you use in your facility. A lot of times they have a gooseneck lamp to, and your job may be the radiologist is here, patient is draped here, and then they may ask you to adjust the lamp lower or higher. It's dark in there, they gotta see what they're doing, right? They're looking for the cervix. Now they have speculums with a light built in, like a little flashlight on a cord. So you have a cord with a little light bulb at the end, and it sits right there on the lower part of the speculum.
Nice.
And lights up everything. So that's a lot more efficient than using the gooseneck lamp. They're able to see a little bit better. Sterile gloves, of course, the betadine, and KY jelly to go on top of the speculum when it's inserting. So there are your pictures of the metal one. There's your plastic ones, the tenaculum, different ones. The uterine sound, this is a metal one as opposed to that. So patient positioning, very easy. Typically we do AP, of course, and then pretty steep obliques, 45 or more degrees to get both sides. You can do a lateral, but typically we don't. Do the doctors make them turn all the way up on their side? Yeah, because the pelvis obscures that area, so the bone's going to superimpose on that. So typically AP and both steep obliques, and the doctor may do different degrees of obliquity with their spot images. If you do have to take a scout film, do you take a scout? Okay, maybe the doctor just looks with fluoro. If you do any type of overheads or scout images previous to the exam, have you ever done a bladder shot? Have you ever cut off the symphysis pubis on a KUB and then you do the bladder shot? Okay, 10 by 12 crosswise, put the top of the 10 by 12 at the level of the iliac crest and shoot it. And that's what you do for this. So your centering is 2 inches above the symphysis pubis, but you're not going to palpate for that. You just find the ASIS or the iliac crest
You put top of light
and
filter
go
in
2 inches below that. So it's easier just to get a 10 by 12 crosswise. Of course, if you're doing digital, you can't, but you can still feel for the iliac crest, collimate to a 10 by 12 crosswise. And then just put the light field at the top of the iliac crest and you're probably going to be okay with that. We do use a grid, even with fluoroscopy, you'll use the grid and, as I said before, 10 by 12 cassette crosswise. And so those are the images that you're looking at. Like I said, before the exam you may do a scout film. After the exam you may do another image just to see how much contrast media has been expelled from the uterus afterwards. I don't know, it's just whatever your department policy calls for. And so looking at that, you can see the problem with a speculum that is metal. Okay, not that we need to see that area, but you can't see anything else. And there's the uterus here. You see how it's kind of tilted a little bit? And then again, you see contrast media coming out. So, and again, this is all that we're doing. We're just looking at this area. The bladder would be right here.
So if we don't have leakage, what does that do?
That means the tube is blocked. If you don't see leakage, the tube is blocked somehow. They may not know what. And so that's when the doctor can force it a little bit and try to open it up, stretch it out. A lot of times, women who get a fertility workup, and this is part of it, this kind of clears open and stretches out the fallopian tubes, and they get pregnant afterwards.
I heard the technical of the patient. So you're not supposed to have sex like 24 hours after, but as soon as that 24 hours is done, what?
Yeah, right.
Go at it.
for it. Because everything's
Let her
cleared
rip.
out. That's right. Yeah, and she's right. You can see, okay, no spillage here onto the patient's left side, and then a little stenosing right there. So while the contrast media is going through, it looks like there's some sort of issue right here. So It looks like the patient is, it looks like you're looking at it straight on, but
It's an oblique, right?
Oblique.
Yeah.
Uh-huh. Just telling you, it's not always. Here's an IUD. Now this is, you can see an IUD on just a plain radiograph, but where is it? You can't see, where is that in relation? IUDs can migrate and become ectopic, and so remember one of the indications was a contraceptive device, so we know it's there, but we don't know where in there it is. Is it still in the uterus? Is it somewhere else? Is it out of the uterus or wherever it's supposed to go? Here's an ultrasound. Here's a fluid-filled bladder right here, and there is the ovary. So this is part of the uterus, and there is the ovary. And we always you can see where we measure the ovary. Here's another one. We measure length, width, and depth. Fluid-filled bladder here. And all of this is just valve. Here's the uterus, looking at it under ultrasound. And there's the vaginal canal. You can see the collapsed tube right here. Again, the fluid-filled bladder. And remember, the uterus was like this, and the bladder fills up and lays it out. The transducer is up here on the patient's abdomen, and we can get a nice pretty picture seeing that all the way from the fundus body of the uterus. Oh, here's another one. Notice this one's tilted. We call these filling defects, meaning contrast media is not filling up in that area, so there's something there. So it looks like I don't know if these are fibroids or not, but apparently something is there, and there's another one there. So you can see there's some problem. Although you can see the fallopian tubes, it's not causing the contrast media blockage, but it may impede fertility if that's what they're concerned about in here. But again, one of the indications was a leiomyoma. What's a leiomyoma? What's the common name for it? And I just said it. Fibroids. Yeah, leiomyomas are fibroids. They're smooth tumors or non-malignant. Okay, so when I say smooth, I'm talking about the borders. Smooth border. They can. Fibroids, it depends on what you want to do. Fibroids can be either in the endometrium or the myometrium in the different layers of the uterus, and they can be taken out. They go typically trans-abdominal surgery, cut in, and have to cut them out, depending on where they are, if they're in the tissue. So some women will like to leave those, as long as they're not causing any pain. Sometimes they grow, and they can hinge on nerves, surrounding nerves, and cause pain, or they may cause fertility issues, depending on where they're located. Like I would think this one is, if this patient was trying to become pregnant, that might be an issue right there, that is right there at the fallopian tube.
I had a friend in this case with fibroid, and she was doing 4 months. That's what I was wondering what they would do.
That's, I don't know why. I don't know why fibroid would cause a miscarriage. I can see a fibroid not allowing the embryo, but I don't know about that. Maybe, and it might have been an incidental finding. I don't know. You can see here is the speculum. Some contrast media has leaked back down into the vaginal canal, and that's fine. It just leaves less for up here. I see some spillage over here and a little bit over here, although I don't see the fallopian tube so much. Do you know what that is right there? You see the catheter, and then there's
That's
the
the balloon
air-filled
tip, huh?
balloon. That's the balloon tip. They don't have the balloon tip secured against that internal os, and so
That's why it
it's
leaked back
leaking
down.
out. Yeah, it's leaking out. So the doctor can insert the cannula, blow up the balloon, and then tug on it just slightly to make sure it's firm against the internal os. I don't know if you can see this. This is an X-ray. Now I found this in our case file, and you will never, ever, ever see this. I've never seen it, and I've done a lot of HSGs and a lot of imaging. So here's the uterus filled with contrast media, right? But yet, again, this is hard to see. Let me find, I don't think there's a head.
There's a spinal cord, isn't there?
There's ribs. Can you see where's the spine? It's hard to tell on here. Oh, yeah, right there. I see it now. I have to stand back. You see the spine and
Oh,
the
okay.
ribs? I do not see head. That's usually when we do ultrasound or typically ultrasound, we always look for the head. I mean, to get oriented. You know, how is the baby down, up, how are they? So this, it says, and this is how I found it, extrauterine pregnancy. So sometimes the embryo doesn't stay in the fallopian tube. It can come out, the fertilized ovum can come out and embed itself in one of the organs of the abdominal cavity.
I heard a lady carried a baby full term on her liver.
Theoretically, was it viable?
Yeah.
Okay, well, happy ending.